Do you want me to admit everybody?
Yes.
Okay.
Hey, Tom.
Sorry, I'm no help.
I had like eight chats going, trying to like figure out like how do we get in? How do we do this?
Mariana has solved, I think, a lot of those technical problems, but now you're an expert.
Oh no, it's Taylor. Taylor's gonna run Zoom for me. She's gonna be my right hand woman today.
Taylor is an expert.
I chatted her. I was like, "Do you know how to do all of this stuff that like Caitlin had laid out in the instructions?" She's like, "Oh yeah, that's easy." And I was like, "Can you help me, please?"
I know that feeling 100%.
Oh, it's so stressful. I hate it. Taylor, are you seeing interpreters anywhere?
Not yet.
Okay. It's
The
just
read AI joined. Do we want to keep that or remove it?
we need to remove it actually.
I had that particular question come up yesterday in a meeting with CBHC and other uh, comprehensive safety net providers, and one of those providers wasn't able to join. And so they sent their AI, and we did need to remove that also. There's only one that we are allowed as a state agency to have in. So, and the problem is that other AI, we don't know how it stores its information. So if we say anything that contains identifying information, those kinds of things, that may go to a cloud that's not secure. So that's the concern, just in case anybody on this call had um, sent their AI and it's like, hey, wait a minute, I really need that. So if people require that as an accommodation, we can include our own AI and then send out transcripts if that was part of the reason for that.
We'll send out notes and everything. So
Yeah, thank you.
good morning, everybody. Give it a few more minutes.
Good morning.
Everybody enjoying our beautiful weather before it snows this weekend?
It's not gonna really snow.
I mean, I'm not going to get any snow where I'm at. I haven't gotten snow like all winter, so
I feel
guess we'll
like
just get rain.
people who aren't from here complain that it goes from like spring to snow in like very early spring. But like I know that like real spring is here when the snow is like wet and temporary and not like 0 degrees. And then I'm like, well, it's still gonna snow. It's just spring snow. Like
Right?
if your concept of spring does not include snow, you are not from here.
True statement. So, I grew up in the Midwest, so our version of spring is thunderstorms and tornadoes. So pick your poison.
We wait for like July for that here.
Right? Colorado gets everything. It's fantastic. I'm trying to see how many participants we have. 11. Has anybody heard from Ms. Jen Vasquez? I know she was planning on attending. Board chair. I'll wait a few more minutes. I apologize now if it gets noisy behind me. My kids are on spring break. You know, and they're kids. They don't believe in like conflict resolution and talking to each other at a normal volume. Well, it is 10:04.
Sad part about that, Jessica, is there are some adults that still haven't mastered that.
That is a true statement. Like, we're having some issues with finding our interpreter, so give us just a second. Hopefully we'll get started here in just a moment. Michelle, are you comfortable being temporary board chair since I don't see Jen?
Sure. Let me pull up. Can you see all the, let me see all the participants. So I see board members. Cassie, Hal, Karen. 1, 2, 3. We do not have a quorum. Let's see. Yeah, 1, 2, 3, 4. Am I counting correctly? There's only 4.
I say I'm a board member also.
5. I forgot to count myself. Yeah, I had you in there.
Okay.
You and Cassie, Hal, Karen, 4, 5, me.
And Katie.
Katie, hi, Katie.
And I apologize also. I don't have all the board members memorized. Stepping
6.
in to like pretend to be Caitlin is like gigantor shoes to fill that I'm just never gonna be able to actually fill.
6, Samantha. I don't remember how many we have total because we just added some.
I think we have 11 total, I think is if we look at when we look at the meeting minutes approval for February, it says we have 11.
Okay. Beautiful. Do you want to pull those up while we're waiting, if in case anyone just wants to review last month's minutes?
Yes, I can do that.
For review. 1,
To just let me know when everyone's ready for me to scroll.
Oh, that's right. This was the meeting I had to miss. Judge Ely's transport order was reviewed. Those of you who are here board-wise, were any of you not present at last month's meeting? Katie, Karen, Hal, Cassie, Jessica, you were here. Katie, you were here.
This is Cassie. I
Yeah.
wasn't.
Scott, James, Jessica, So Cassie and I were not there. Okay. Um, you know what? If there are those of you who know voting protocol better than me, Cassie and I were not at last month's meeting. So I know we actually cannot make a motion or second a motion for the minutes to be approved. But because we weren't there, I'm not sure we can actually vote, period.
That's a Caitlin question.
That's a Caitlin question. Not a huge ordeal. I mean, we can always just approve these at the next meeting.
Yeah.
So that's not a problem at all. Keep scrolling, would you mind, Jessica, please? There we go. 2765 tribal court orders. Yes. Beautiful. Okay.
Going.
Innovative ideas. I love our innovative ideas. And I don't know that we discussed how to prioritize these, when to take something off this list, and when to move forward on it. But that I think is part of this year because we're going to be doing our recommendations. So these are some monumental undertakings.
Oh, for sure.
Okay. A lot of time. Aaron. Okay, if everyone's okay, we'll just put these. Is there anyone that has reviewed the minutes that has any comments, though? Anything that was incorrect when you reviewed it? Again, Cassie and I were not there at last month's meeting, but if anyone has any comments, things that are not correct or things that are missing, please feel free to speak up and we can make any of those adjustments.
Nothing is standing out to me as being incorrect or missing. But I don't remember everything probably, but
come on now.
You know how much has happened between then and now? Yeah, no. It looks good to me, but
I've slept a few times
that's
since
right.
Monday. Okay. So we'll just take note that we will vote on meeting minutes next month,
Sounds good.
just because I want to confirm Cassie and I being able, it looks like we have a quorum with us, but I don't know that we can vote on those having not been there. I apologize. I don't know that minute detail. Who's taking notes? Jessica, are you?
I am going, so here's kind of what we're doing on the back end. We've got everything recording and I will go through and take like really detailed notes from the recording. Because if I try to do it right now, I won't be able to give my full attention to either. So
beautiful. Okay, so we have our board member roll call. I went through all those. Jessica, Cassie, myself, Hal, Dr. Rice, Katie. So there's our board member attendees. For today's agenda, and again, I apologize for Tuesday. For today's agenda, we've got a couple things that are going to be presented by our phenomenal BHA. We'll vote on minutes next time. Board recruitment, again, not having been here last month, but I think we are still working on filling some seats. And the seats that are being filled have specific membership requirements. Jessica, you don't know what's open at the moment, do you?
let me look and see if
Public seats.
Yeah.
Hospitals.
We have our medical director one is open. Let me look at membership.
Dr. Simpson doesn't qualify for that. I don't know what he's.
It was Dr. Renee Marquardt originally, and so I don't know if we can just slip somebody else in there. Part of Caitlin's responsibilities also is recruiting, with her being temporarily assigned. I know Ryan Templeton and Andrea Jones are going to be kind of taking that on. And unfortunately, I don't see either of them here to kind of discuss
Okay.
any plans moving forward.
Okay. Okay. Well, just keep in mind there are, I think, 2 board seats open. Maybe 3 if I'm missing one. But they do have specific roles. This is a board that is appointed, so we must have people sitting in certain roles that come from certain areas in the community, certain industries, certain fields, certain representations of our population and service providers. And so we'll get those. If you know anybody who might or you would like to reach out to Caitlin and just ask her what seats are open. And again, like Jessica said, she's in charge of that.
And I'll dig into that, and kind of when we send out like minutes and things like that, any updates, I'll look and see what vacancies we have. I just need some time to
Perfect.
dig into all the boards and commissions folders that we have.
Perfect, perfect. If you could scroll a little bit, the last one on the agenda is the 2765 questions. Usually we have added to the agenda in the beginning any of our public participants who show up to the meeting. If you have anything particular for public comment, we always do that at the end. But in looking at the agenda, if there are specific questions or additions you would like to add, we typically do that in the beginning. So if there's anything specific, please think about that, as we'll come back to that as we close up at the end. Would love to hear from you, questions or comments you bring from your respective worlds to this arena. 2765, review and updates, eating disorder licensing manager position. There you go. That's a fun one. CCBHC updates. Tom, so good to see you again. And then ASAM 4 changes that are coming up. I don't know how many of you know about all the different changes with budget and cuts and things like that, but go ahead. Tom, are you going to start? Who's doing the eating disorder update?
I was going to do the eating disorder update. It's just a very quick update because we're still trucking right along with our eating disorder task group. Unfortunately, I had to cancel last week. I was out ill. However, we closed the position last week. We had 17 applicants that made it past minimum qualifications. And so we have offered interviews starting next week and the week after to the top 6. And we'll just kind of keep you guys posted as that comes along. I'm very excited to get that ball moved forward more.
Beautiful. Oh, and so you're finishing that process with those that are qualified, and then you'll make the final decisions later.
I'm hoping by the time we meet next board meeting, I will have at least a verbal offer out to someone. That's my fingers crossed. That's my goal.
Fantastic. Tom, the floor is yours. CCBHC planning grants.
Thank you for that. I am not very good with screen sharing in the Zoom format. And what I hear other people say when they try to do it is, I can't see the slide. So are all of you seeing a slide entitled CCBHC Planning Grant Goals?
We are. So far, you have an A+. Nice.
Yay. It is so weird that I can't see that. So that makes it a little awkward, at least for me. Now,
That is weird.
I have 3 slides that I want to use just as a basis of presentation, but mostly I want this to be a conversation. And because I haven't been to the group recently, I don't know whether we have a variety of knowledge bases about CCBHC. So, for instance, Dr. Rice, I know you know a lot about it. I don't know if other folks are like, what is CCBHC? So, I want to do just a little bit of level setting, and my apologies to those of you who are experts and probably even know more about it than I do. So CCBHC is really a federal model about behavioral health. And the feds, primarily through SAMHSA, give out what are called planning grants and then demonstration periods for states that apply and receive those grants. And then through that grant, say, hey, we think that we and that particular state could benefit from introducing this model to expand behavioral health services in the state. And part of what it comes with as an enhanced or greater match from the feds than would otherwise be available through Medicaid. So that's part of the financial incentive for a state to do it. It also comes along with additional regulatory criteria. So it's not just more money, it's a new regulatory and data collection model. That's probably the top line here in terms of what CCBHC is. I'm going to
Could I
pause.
pause you really
Yes.
quickly, just for anyone who's on the call? Is there anyone not familiar with what CCBHC is? Tom, would you mind just giving a 2-second explanation just in case anyone doesn't have that, just 1 or 2 sentences?
It stands for Certified Community Behavioral Health Clinic. So that's actually what those initials mean. For folks that may not know, well, what does all that alphabet soup really mean in terms of a facility type? So that may be the best way to ground it. Colorado is a little bit different than other states, and I'd say we've been out front a little bit, particularly with the adoption of essential and comprehensive safety net providers. So what CCBHC requires is a certain kind of service delivery model. It says that any organization that applies for and becomes a clinic under this model has to do a certain set of services. Now, here's the good news is that those set of services are almost 100% aligned with what a comprehensive safety net provider is required to do. So all of this sounds very complex, but at the very base level, a CCBHC is not entirely, but pretty closely aligned with comprehensive safety net providers. I hope that helps, Michelle. Is that
Yep, that's
that sound
perfect.
like
I just wanted the kind of explanation out there just in case. We throw around a lot of acronyms in our world. Thank you for that.
And I very much appreciate that question. And that's exactly what I want this to be as a conversation. I just don't want to rattle on through these slides. I want to make sure everybody gets what CCBHC is in terms of timelines, concept, payments. I'll try to answer all those questions. So please stop me just like you did, Michelle.
You bet.
So this first slide is really a lot of what I just said in terms of this period, the planning period, which runs through December of this year, is for Colorado to figure out whether this is a good model for us to adopt. So we're doing this effort in combination with HCPF, Healthcare Policy and Financing, who is technically the recipient of that grant, though we are partners with them, but they're the primary investigators. That's federal lingo, the PIs on this particular grant from SAMHSA. So in essence, during this period of time, calendar-wise, we're determining whether this will be a good model. Now, let's see. This is really a breakdown in terms of what needs to happen during this planning grant period. We have formed steering committees. People applied. It was a competitive application process. The identified members from each department ranked all of these anonymously. through a competitive process. And then though all those rankings went together, and then HICPUF sent out notices to folks that scored the highest for those individual steering committees. And then part of what we're going to focus on through those steering committees is determining what population and service areas are. Again, a lot of this aligns with comprehensive safety net and the call of the statute that formed BHA and that we have in our regulations right now for safety net providers, but determining what the needs of different service areas are and priority populations. So you're going to hear a lot of language that is similar to comprehensive safety net that already exists. And the reason that is when we were drafting those regulations for safety net providers and comprehensive in particular, is we looked at the CCBHC requirements when we wrote those regulations. So we figured CCBHC was coming. It's a federal model. We're going to do our best ahead of time to make sure that those regulations already exist. And I thank Eric Gannett every single day, who was the primary author of that particular regulatory chapter, for having the foresight to know that we would very much, or very likely to be a planning and demonstration state. So next part in here in terms of timeline before December of this year is that we need to get this word out and do education and training of the community in general and potential clinic applicants in particular. Two main focuses here, infrastructure for data quality. So there are lots of measures that BHA has to collect from any organization that applies for and receives certification to be a clinic. There are actually more reporting requirements than we currently have for comprehensive safety net providers. So it's a big deal in terms of what we're going to ask these clinics to report and how we ask them. So what systems do they send that information in, how we aggregate that data, and then report it back to the feds. We're spending a lot of time and effort talking about that. That's actually probably the most complicated part about becoming a demonstration state. The next big thing is this line scope and of services and certification. And that's primarily landing in the quality and standards division. And that is a lot like the other regulatory oversight that quality and standards does for the almost 900 licensed, designated, and approved facilities throughout Colorado. We're going to develop a whole set of standards for these clinics so they know to what base requirements they must adhere to. One, be approved as a clinic, and then remain approved as a clinic. Again, it's going to look a lot like what it takes to be a comprehensive safety net provider. And so that one is an advantage. Two, the other edge of that sword is we assume that a lot of the applicants are already approved as comprehensive safety net providers. So what does it mean to be both? How do we distinguish between the two and not have unnecessary duplication? So we're trying to get our heads around that and do some drafting in the regulations about that. The other parts here, last couple lines, establish CCBHC PPS. That's the prospective payment system. This has much less to do with BHA and much more to do with healthcare policy and financing. But that's been part of what the community is very excited about is, does this mean higher rates for organizations that are certified to be a clinic? And so HICPUF has had several community meetings to talk about PPS rate options. It's my understanding that there were 4. They're narrowed down to 2, and then asking for input about what of those 2 would be most beneficial for folks. The takeaway for me is there may be more opportunities for billing across a larger set of categories, but there are more requirements. So HICPUF, I'm trying to paraphrase what I hear from HICPUF. Their concern is this doesn't result in a net increase in dollars to potential certified clinics. Now, I don't want to hide the ball. I think that that may be an area of concern for folks that apply. Again, that's not necessarily directly in BHA's scope of authority, but those are the kinds of things that I try to stay abreast of. Happy to take any questions about that if I can answer. The last here is approval for CCBHC. So this is really about, hey, did we do enough good work in terms of preparation through these subcommittees, setting up the PPS, doing our regulatory draft that talks about the certification part and the data collection part, to say to the feds, we nailed it in terms of our planning grant period. Please approve us for demonstration. So that demonstration needs to primarily focus on quality measure data, the prospective payment, and then the certification and provider readiness. And all of that turns into a bundle for an application for that demonstration. And if the feds give that to us, then we would be CCBHC state for, it's my understanding, 4 years during that particular time. That was a bunch of stuff, I think. What questions do people have?
I have a question with the recent SAMHSA cuts. The list I have seen does not include anything related to CCBHCs. Is there any concern? Well, who the heck knows, right? Is there any concern that this is going to be, we're going to have to change things up because of SAMHSA cuts? When they say that, we're getting the federal dollars potentially for this, I guess I don't quite understand. Is that actually money coming from SAMHSA? So if they're, okay, so potentially more SAMHSA cuts would put this at risk, potentially. But as far as we know right now, that's not part of the funding that's been cut. Am I correct with that?
You are correct with that. I asked almost word for word the exact same question when we met with our federal partners earlier this week. And I said, wow, is CCBHC surviving through these cuts? And the answer was, as of today, yes.
Okay.
The next day, at least we heard that SAMHSA got moved to a different federal department.
Okay.
That there were staff cuts, and then where they were located in federal government shifted. So it certainly makes me think there are more changes. Am I in a position to predict whether it survives or it doesn't? I'm certainly not.
Right.
But
at least you were privy to that meeting. So that's, not that any of us have any sort of security right now in terms of what's going on, but.
I'm not going to pretend I'm not worried.
Yeah, right. I think we'd all be naive if we weren't.
Right.
Yeah.
And I think everyone on this call knows that we got unfortunate news with regard to SAMHSA mental health and substance use block grant dollars across 4 different funding lines, and that went to approximately 30 different Colorado organizations as more or less pass-through money through us. It totaled about $30 million. 24 million of that was essentially encumbered, and it was a hard cutoff Monday of this week. So is there more to come? We haven't heard anything that there's something else looming, but again, I think we're all worried that there may be. I don't want to hide the ball. I think that these are real concerns that we have. So I very much appreciate the the question, Dr. Rice, I would just as soon have these conversations rather than pretend everything's fine.
With that, do you know like where the CCBHC prioritization is? Or any kind of additional insight you might have with, where this sits on the prioritization list?
I asked that question as well. Here's the response I got. CCBHC has both parties' support at this point. I don't know that wasn't necessarily 100%. Oh, I feel confident at this point, but that is the response that I got.
Sure. Thank you.
Appreciate you asking. Any other questions about that? Any part of CCBHC or how it dovetails into budget concerns, et cetera? Let me say one more thing is it concerns timing for CCBHC, and then this also gets a little bit into ASAM 4. I'm no subject matter expert when it comes to the very specifics when it concerns ASAM 4.0, so these comments are really just about the timing. And we've spent a lot of time just in the last week working on when these things would spring into effect, because both require regulatory drafting on the part of BHA. So the first thing is just an infrastructure that may be of interest to you. I'm in the process of building out a regulatory affairs unit within the Quality and Standards Division. It's going to be 6 or 7 people, most likely, that will take on a variety of regulatory chapter drafting. So those specifically are provider rules, the things that I'm sure all of you are quite familiar with, that deals primarily with organizations that are licensed, designated, or approved. Then we have system and admin rules, system being primarily about the kids system, even though some of that exists in other state departments, but specifically about assessments for kids. And then administrative rules is a relatively unused regulatory volume for us. We intend in the future to have that be more of a billing methodology and behavioral health administrative service organization focused chapter. And then the fourth is CCBHC. So I'm building out a regulatory unit, and we're going to have subject matter experts that are going to be primary drafters for each one of those. We intend, whenever we make changes of those, to share those with the community, get important feedback, make alterations to those chapters before we present to State Board of Human Services, which is our type 1 agency for everything but system rules. And then Commissioner Smith is the authority to approve those system rules. So that's the regulatory background on those things and what we're doing in terms of the infrastructure for it. Timing wise, both CCBHC and ASAM 4.0 really need to be in place, meaning the rules would be effective July 1st of 2026. Now, we can't just say the rules are ready to go then, so the following day, on July 1st, all these organizations will be sending in new applications on that day. So we need to back out from that July 1st deadline to when the rules are approved, so organizations, whether it's ASAM 4.0 or CCBHC, know what they're applying for, what the requirements are. So both we intend to have regulatory chapters drafted in time for them to be approved. That means the State Board of Human Services will approve the rules, so organizations can look at those, even though they're not effective, to know to what standards they must adhere. So we intend to go to state board probably late winter, early spring next year to do the two readings. So the way it works is we'll do the first reading, have a month off, make any changes that the board says or anybody providing testimony in those hearings. Go back for our second reading. Hopefully the rules become approved on that date, and then everyone knows what those final rules are, even though they don't become effective. And that's our busy period in terms of dealing with applications, both for CCBHC and for ASAM 4.0. And then again, they become effective on July 1st, but hopefully we've got a pile of applications, which we've already vetted and got those organizations going. Okay, again, a bunch of stuff. What questions do people have?
It's a long road.
It is a long road, and I frequently feel overwhelmed when I think about what the deadline is more than a year from now, and then build a plan that backs us up, and then I feel very old and tired. But that's the best way to do it, to make sure that we reach our targets.
Yeah, I agree.
I didn't, not hearing any questions immediately, at least. I didn't necessarily want to step on anyone else's toes in terms of ASAM 4.0. I only wanted to talk about timelines with that particular change. So if I can't answer any other subject matter expert kinds of questions with ASAM 4.0, I can certainly write those questions down and then bring them back to this group or get them to members in the meantime.
What are the biggest changes? What are the most salient changes with ASAM criteria?
So just to make sure everyone understands, ASAM is really a third-party organization that creates service standards which have primarily been rooted in substance use type services. And what's happening with the fourth edition, there's a little bit of confusion, and I realize I've created that. We're not talking about level 4.0 in ASAM. We're talking about the fourth edition of ASAM. And the fourth edition seeks to combine, not 100%, but more, the concept of withdrawal management into all levels, or all residential levels, of substance use services. Now that's great, because we know that withdrawal management is in a lot of cases part and parcel of any substance use service. Now, practically, what it means for a lot of organizations is they don't have that infrastructure, either in terms of their physical plant or in terms of their current staffing models. So we are making these regulatory changes. Members of my team, in particular, Mariana Sears and Mel Tyler, are doing a lot of meetings with the community, particularly for folks that are doing level 3.2 that don't have withdrawal management embedded in it right now, about what it takes to make these changes organizationally speaking. In addition, we've engaged a third-party vendor to help for that technical assistance to make sure that they are able to make these changes organizationally. So in combination with our own technical expertise, that of HMA as a vendor, and then this time period with trying to get rules approved next spring and then effective July 1st, we hope that that's enough of a runway to make sure that we are expanding this type of service, the withdrawal management service, without losing any providers, because I think that's the concern. While this is way more than we're currently doing, and I don't know how to expand my organization to do all of this. So who's ever sharing their screen was probably like, yeah, I was supposed to talk about that particular part, so thank you. very much for
Okay.
including this.
Well, and I think it's a really good segue because really what I was going to focus on with the ASAM4 was how it was going to impact 2765 specifically. So that's wonderful. Thank you so much, Tom, for all that background, because that does help kind of level set what we're looking at. So this is kind of our future state build out, and you can see everything in black is kind of where we're headed, and everything in purple is kind of where those current levels are and how they're going to be implemented in the new build out. Where it's going to affect 2765 the most is going to be in our crisis system. And so this is really kind of that opportunity for us to discuss this a little more. Part of it is, if you can see under crisis system, there's no longer ATU listed. And so one of the pieces of this ASAM4 build out is collapsing CSU and ATU into a single crisis type, with the addition of like a behavioral health crisis center, urgent care, kind of one-stop shop. In addition to like walk-in crisis, mobile crisis, respite, there's all kinds of other pieces. But you can see that with like the behavioral health crisis center, the urgent care, that name is still to be determined. It's going to be a combination essentially of what we have now with the CSU, ATU, that 3.2 withdrawal management that is going away entirely, and a walk-in crisis. So that's why I say one-stop shop. This is going to be your catch-all. Any community provider that has this particular license type will be able to serve anybody that walks through the door, regardless of what type of crisis. And so one of the things that we have distinguished to help kind of separate it in our minds is this 3.2 withdrawal management is really going to change to like intoxication management. So it's less of like managing withdrawal after they're no longer intoxicated and more just helping in the crisis moment. So same thing with like the CSU ATU combination. They will have protocols in place to assist with that intoxication, and then through assessments, through wraparound services, kind of figure out where is the best place for this person to have longer term care and treatment. So really, I wanted to focus this conversation and kind of open it up to everybody to kind of talk through like, what are your concerns with the collapsing of these? And we've done a lot of this. Mel and Mariana really have done a lot of like community outreach for current providers that are either in the crisis system or people that currently have a 3.2 withdrawal management license, to kind of discuss like, here's where things are going. How can we support you? There are a lot of things that 2765 does not specifically speak to, is what I will say. And so we have an opportunity to build something really wonderful between this walk-in crisis center, the behavioral health crisis urgent care, and a CSU, to make sure that our communities are getting a full spectrum of services that they need in connection to other services.
Jessica, can you scroll up just a little bit? I have just a couple basic questions. Okay. I am not someone who resides in the substance use treatment world. CM and MM stand for, please?
Clinically managed and medically managed.
Beautiful. So this is where, when I asked that what is changing with ASAM 4.0, the reason I ask is because the last changes I heard was this 3.2 detox is going away. So when it says residential, that simply means they can stay there, and it's going to go from a 3.1 to a 3.5, and this 3.5 is absorbing what used to be the 3.2 licensed centers. Is that it?
That is my understanding as well.
Okay.
Well, and also, I mean, I think I've been very involved because we have a 3.2 at Clinica. It's like, where are those current 3.2 patients going to go? So, based on this chart, there's a number of places they can go. And I think, you're going to have, and another key point here is, the 3.2 was considered a quote unquote social detox with, no requirement for really medical involvement oversight. And I think, by putting, basically you're medicalizing withdrawal management in a way that maybe wasn't, whereas other states have kind of moved away from this for a while. Colorado was one of the states that still had this social detox. So, with this new system, you can move the 3.2 folks under this BHCC. You can put them into the level 3.5 residential, and you can move them in just with regular crisis state, or where's the other one? With your crisis system without a CSU and ATU, I believe.
Yeah.
Because that's what we're looking at doing. So I think that's a little bit more background, but and people on this call have heard me kind of with my biggest concern thus far, and it sounds like, Tom, this is something you're now tasked with, in just making sure now the regulations work for the new types of folks we're getting. For example, if someone is going into a crisis setting and you need to do a crisis assessment, for example, if someone is intoxicated, you can't do a crisis assessment on them. So, if that's a requirement of kind of getting reimbursed, what is that going to look like? And these are people that often come and go very quickly. I like the term intoxication management because that's exactly what it is. So what is it going to look like in terms of what we're required to do with those folks that are now coming into our crisis facilities? Are they going to be subjected to the same crisis regulations, so to speak? And that across the board, like no matter where these folks go. For example, if they went in 3.5 residential, not everyone that wants intoxication management wants to stay in a residential facility. So, like, what are those regs going to look like? We have at our place the potential to have both a 3.5 with the withdrawal management and the crisis with the withdrawal management. But if you don't have that ability, and the only way you can take people that are kind of intoxication management, the only way you can do it is through a 3.5, are you then going to inadvertently cut off a bunch of patients from services because they just don't want to stay there for 2 weeks, right? If that makes sense.
My understanding was that your CSUs and ATUs and walk-in centers, and Tom and Jessica, correct me if I'm wrong, those facilities, those licensed entities would not allow someone who was intoxicated, or whether the licensing would allow, the staff would say they cannot come because they're intoxicated. So this now, Jessica, I love the way you phrased it. Folks can now receive this service, but on the back end, what I hear is agencies must now provide this service and allow these individuals in. Is that what this is doing, essentially, is allowing these, what used to be very mental health based, sorry, they're intoxicated, they can't come. Now they will allow them, because I was told you do not have to do that crisis assessment intoxicated right when they walk through the door, but it will be part of that. Dr. Rice, to your point, what if what I have said is correct and what is incorrect? Fix the rumor mill.
I think you're on track. Really, the purpose behind this and the ASIM level 4 is to get rid of more of this bifurcated system, right? Like, we're trying to have the whole person be treated instead of just mental health and just SUD. It really is supposed to be this combination. And we do see some agencies are doing this where they have the ability to do some intoxication management with people who have pretty severe psychiatric symptoms. And sometimes you can't tell, right, when they first get to you, right? So it's another way to kind of treat the whole person. So one of the things that we're trying to help manage, as far as like the anxiety level around this, is people who have that 3.2 who might be wanting to transition to either like this behavioral BHCC or the CSU, is having that 2765 designation requirement, because a lot of people are afraid of it. And so it's really, it's more than just people who have only done mental health now taking on SUD. It's also the other way around, right? So we're trying to figure out, how do we best support our community, our providers? And because this is brand new, we have an opportunity to kind of come together to build this system as one instead of just a few people dictating how it's going to look. So it really is a wonderful opportunity to help whole person.
I see that under crisis systems, ATU has disappeared,
Yes.
but under the Behavioral Health Crisis Center, it includes CSU ATU 3.2, which is going away, and WIC, which is down below. What is the proposed? Are ATUs going to go away and CSU is going to be the thing? Are ATUs and CSUs going to go away and BHCCs are going to be the whole thing?
So everything in black is future state of kind of where we're headed. And the purple is what current state we offer is going to be incorporated into that. So under CSU, you can see it says CSU, ATU, and 3.2. So ATU, CSU is collapsing into one. And we're just going to keep that CSU title.
Got it.
However, like traditionally, CSU has been very short term, 3 to 5 days, whereas ATU has been a little bit longer. We're going to be looking more at that longer term length of stay and some more of the ATU requirements around that in order to incorporate that intoxication management part.
Amazing. You know, the other thing you mentioned was I very much sit in the world of mental health and hear all the substance use disorder treatment being incorporated, and for lack of better terminology, feel like for many, many years, I'll say mental health and people will correct me and say behavioral health. You have to pull all of this together. But when I sit at tables that are primarily recovery centers, detoxes, and peer-based treatment and longer term recovery, they are very much SUD and don't consider themselves mental health. It's like they want to keep that, is the impression I get. I feel like it's very segregated when you stand on that side of the table, and not as much on our side of the table. I don't know, maybe that's just my perception.
Dr. Raish, you have your hand up.
Well, it's interesting. Before I say my thing, I wonder if that's a relic of being kind of protective in terms of what services they have. The SUD community has been so outside. I mean, I think of it even similar to a lot of what I personally am feeling right now with being a psychiatric provider that's now merged with the FQHC. I feel very protective of psychiatric stuff, and I don't necessarily think it's a bad thing. I think it's just kind of to be to be expected when you're maybe used to being the marginalized group a little bit. So I don't know. I'm totally just throwing that out there as a hypothesis, but yeah, I think when you're used to kind of being the one that's marginalized, you're very protective of what you have, and you don't necessarily are as eager to join potentially. But speculating here. Anyway, sorry. I guess you guys met. There was a meeting on Tuesday that I was unable to attend, and I think this is where you unveiled this, Jessica. Okay, so now that I look at this more carefully, we at Clinica we have a WIC. And there was talk that we would potentially be able to add the 3.2 withdrawal management to the WIC. You've made a decision that will not be happening?
I think that's going to fall under that BHCC.
Okay, so if we don't have, we do not have a CSU or ATU, nor can we because of various staffing requirements. Basically then, the only way at our agency we can have withdrawal management services is if we start at 3.5, because we won't be able to roll the 3.2 into the WIC. Am I reading that correctly?
No, you should be able to. I mean, if we're still talking like 23 hours and not overnight care, there should be a way that we can roll that in. And maybe it's not reflected in this particular table. But
So,
I hear what you're saying, and what you're saying I think is accurate. I think we do have expectation around adding some of that intoxication management into a walk-in crisis.
okay.
And I apologize, I did not create this. I stole this from Mariana.
It's okay. I guess I would
Um,
just then, if that was the case, would expect that on the purple side would say WIC, comma 3.2 withdrawal management.
Agreed. And so I might have to go back and do a little recon and figure out like, what are we looking at? What is like the main difference between the walk-in crisis and the BHCC? Like what, aside from like this very clearly shows that there's like the withdrawal management piece of it and there's an overnight component, but other than the overnight component, like really what are we trying to accomplish with these two different types? And so that might just be a little more research on my part.
Yeah, and it's going to make a big difference with staffing because I think with the CSU stuff, you're already kind of staffed higher. You know, for a WIC to then bring on a what is currently 3.2 is going to be a different skill set that you need to bring in.
Yes.
So that could create its own challenges.
For sure. Anybody else have any questions or concerns around like 2765 moving into this or any of those kinds of concerns?
I don't have concerns. I think this is really, fantastic to see the worlds kind of merge from a regulatory standpoint, and from a licensing, standpoint. I am curious to think about what reimbursement, looks like, since we're combining or looking at combining the CSU and ETU, and then how that works under the umbrella of crisis, and then with the SUD benefit. There's two different worlds that fund the services. How is that going to play out?
For sure. And I don't want to speak too much about it because I'm not the expert, and I would defer to HICPUF. But Tom, do you have some insight?
I do have some insight, though what Jessica just said, with this primarily being HICPUF controlled, or really through the raise, is the short answer. The longer answer, and some of the background here, we did attempt to combine the CSU and ATU endorsement types under the behavioral health entity license when we redid our regulations in 2023. And what we heard from constituents was, no, wait, ATU is a higher level of care. And it's, as Jessica said, is typically a little bit longer stay, higher level of acuity. Sometimes there's restraint and seclusion, delayed egress or locked doors. CSU, maybe the opposite of a couple of those things, to make the story shorter. And what we were trying to pitch, regulatorily speaking, at the time is, no, you as an organization having a BHE for that crisis license type can pick and choose which one of those services you do or don't do. And then here is part of what we pitched, and providers, at least at the time, didn't like, is then depending on which one of those aspects of service you do or don't provide, you can negotiate the rate with the RAE. And I think maybe that was just a little overwhelming in terms of the combination of all of those kinds of things and what would need to be negotiated, since the standard practice has been ATUs are typically reimbursed at a slightly higher level than CSUs. So we're essentially saying, let's do that combination now. And then everything I just mentioned in terms of those differences, hey, as an organization, do you want to have it be a locked unit? As an organization, do you want to use restraint or seclusion, which means physical plant changes and different kind of training and oversight from the staff? Some of those things are still going to be optional. The designation, the 2765 designation from BHA, probably not going to be optional. We require it for ATUs right now. And then again, depending on the combination of services, that provider organization is going to need to get with the RAE and say, here's all the things we're doing in our facility. Here's why it's important in this particular community. All of that equals what the negotiated rate is. It probably makes it more complex from a negotiation standpoint. It makes it less complex in terms of licensing and designation.
Mhm.
I tend to over answer. Did that help?
Yeah, definitely for the CSU, ATU, part of things. I think also kind of what Dr. Rice was referencing as far as staffing for the WM. How do we foresee the reimbursement for WM? Because there's two different rates currently for 3.2, 3.7, 3.7 is a higher rate, but if that falls under the CSU ATU, would it really just be what BHCC
I
level of
think
care?
that I'm a little concerned about expressing my opinion about. That's probably 100% a HICPA question.
Okay.
What we can say is we know HICPUF is doing an analysis of what these rates are going to be.
Sure.
Thank you for that, Jessica.
Yeah, no, thank you. I appreciate, just the conversation and obviously all the work being done to merge this care and make it less bifurcated, like you said, Jessica. I think it's strong work.
Thank you.
Any other questions, comments, concerns on the ASAM 4 changes coming? So the thing that we have on our agenda next is around law enforcement training. We kind of talked about this last time. Do y'all want me to share the agenda again? Can we put that up?
No, that's fine.
Okay. And I know we briefly talked, and we do have Taylor Lynn with us today, who is our jurisprudence 2765 training specialist. And so she can definitely speak more to like what we do offer, what we have offered. I know there was mention previously, and I'm sorry, I don't remember the gentleman's name, but I don't see him here. Around potentially training with post and some of the barriers that we've had. Caitlin did share with me an email this morning that came out of the consent decree committee. And then there is interest in creating like a subcommittee out of that, specifically around these transportation issues. Senator Amambale has been working with like the sheriff's department and their collective entity to discuss like what would need to be in place for them to really jump on board with transportation orders and things like that. So it's starting to get some traction is what I will say. And they're going to look at forming this subcommittee for transportation to potentially start creating recommendations for 26 legislative changes.
Interesting.
Anybody have questions, comments, concerns? I know we're moving right through this agenda today, but I want to make sure we take time and care if anybody does have more things they would like to discuss. Additional board recommendations running list. Let me pull up the minutes so we can see that again, because I don't know about y'all, but I don't have that memorized.
No, and it's long.
It is. Innovative ideas. Here we go. So continue to talk about the automation of the M1. This might actually be a conversation with the ASAM 4 changes coming and having less of a bifurcated system, maybe starting the conversations again around this combining the EC and the M1 process. If we're going to have places like a BHCC that can do both, or a CSU that is going to be required to do both, what would that look like for providers? What would we want that process to look like? Because it is very different right now as far as like who can initiate the EC, who can accept an EC. I know I just recently got an email from a sergeant in the community that was very confused around that process. So maybe this is one that we could dig into further.
Yes.
Anybody have concerns with combining? I know I was originally the voice of dissent of like, no, please don't touch this.
Yeah.
Mostly because the EC statute is so limited and it would require significant statute change on both sides for it to come into play.
What would that even entail? Like, I think that's where my head goes is this would require such an administrative burden on the statute side. And I could even foresee it being done and then almost instantly as you try to work it, amendments being made because as you put practice from philosophy, you find that it doesn't work the way that you intended. But, you know, they are completely different processes and statutes. What would this even entail? Let's just say hypothetically, we got the green light and they said, go ahead, start working on this. What would it even entail?
I mean, I think that's a great question. And I think you really hit the nail on the head as far as like, there's so many moving pieces that we would have to care for, right? Like there were things that came out of House Bill 22-1256 under 2765 that we would now have to essentially undo to accommodate some of this EC stuff. Same things with like the crisis assessment, right? Like Dr. Rice mentioned, like we can't do a crisis assessment on someone who's intoxicated.
Right.
What kind of assessments are we doing for someone if they are under an EC? If they're under an EC, are we still trying to push them towards an IC later? Like how does all of that long-term process work? And I don't think that this conversation is something that, one, we're going to solve today, and two, would need to take apart the system. I don't think it's a bad thing, but it is going to be a massive overhaul.
And
Dr.
lengthy.
Yes.
I guess I would want to go back even further. I mean, I'm not an expert in this area, but and I certainly would want lots of opinions and input. But I mean, is this even something like, do we want to do this? Like, there's a lot of kind of pros at trying to combine these processes, but it's tricky. You're taking people's rights away. I'm just thinking out loud here. It's really hard if someone is intoxicated to make those kind of decisions.
Agreed.
It's like versus an M1, the substance use part is kind of eliminated from that. So I almost wonder, is this even something we want? Like, is this going to lead to more problems? Because like I said, I'm not really in this world as much, but it seems to be working relatively well in a way that like I don't feel like people that maybe are just intoxicated for the day are having their rights taken away for 72 hours and so on and so forth. And maybe that's not even a goal we should be shooting for, but I'm just putting that out there.
Well, and maybe it's like we're not combining these processes, but we're adding a process ahead of time for those, like we don't know what it is. We don't know if it's intoxication or psychosis, right? Like, so we are putting them on a 24-hour hold to see what happens in that for 24 hours. And then from there, you would initiate one of those processes. I don't know. Erin?
Yeah, I was just going to add some context. So I work in the Department of Public Safety and am the vice chair of the Treatment of Persons with Behavioral Health Disorders in the Criminal Juvenile Justice System Task Force. And I think this was one of those things that saw some crossover between this group and that task force. And the idea really is around approaching an emergency commitment with some of the same mentality that we approach M1s, largely around not having individuals be able to be taken to a jail under an emergency commitment. I think that was where this conversation originally started and was to recognize that a jail is not a therapeutic environment. A jail is not necessarily a great place for folks to detox. And so wanting to again, recognizing that these things, and I'm not a mental health expert, I'm a criminologist, that these things are distinct in a lot of ways, but that some of the way that we approach the individuals who are experiencing these crises could be a little bit better aligned, from the standpoint of making one a criminal act or more consistent with the criminal act, and another being more medical in nature, just from that kind of initial standpoint of where can folks go. So I think that's where that conversation came from, and why there's some overlap here. And I think this keeps popping up, if that helps for context.
It does. And Katie put in the comment, we did talk about the fact that this is something that's too monumental, but to your point, Erin, there needs to be far more people around the table than just mental health and substance use treatment, because what you're alluding to is if they don't go to jail, you take a violent, unruly, intoxicated person and put them in the ED. And EDs have no recourse but to chemically restrain someone and put staff and security in a position of going hands-on. And so we put an ED in a very precarious situation when we say, do not take an intoxicated person. And I'm not talking about that lifetime alcoholic who is going to start to go through withdrawals when they hit a 2. Again, there's so much, and like Jessica said, we are not going to solve this today, but as we start seeing the ASAM criteria and these facilities start to meld together, I think with the conversation we had before, I would now go back to, and again, this is just me, back to the conversation that was made before with some of the 1256 changes. Let's see how this plays out before we even talk about whether or not this would be feasible. And I almost feel even stronger about that now, seeing how some of these facilities will change. Because if someone who's intoxicated doesn't have to go to a jail, but also doesn't have to go to an ER, and they can go to a walk-in center or a BHCC, that's going to be at least a healthier environment. But the truth of the matter is, every entity involved with this has a very valid statement and perspective on why. It's the hot potato. Nobody wants these folks in front of them, but it's not because people are just being, snarky and dismissive and don't want to do a job. It's an enormous undertaking, and they have some pretty solid ground to stand on to say, hold on, if you're not going to send them there, you're going to send them here. Let us tell you what that means for us. And I think that kind of becomes even the bigger conversation.
Yeah, and Michelle, I don't disagree. And I think that's why this keeps coming back around, is that I think everyone agrees that there currently is no good place for folks in this, condition to go, but that's safe for them and safe for staff. And so trying to kind of have this conversation in a way that helps to solve that problem for both folks. I think at one point, right, the conversation around M1s was a little bit similar, in some ways too, where it's like, well, EDs aren't a great place for folks. Neither is the jail. So what do we do? And I think trying to kind of, again, come at the EC conversation in a similar way that the M1 conversation happened, although it's, as you pointed out, much more complex. But starting to have that conversation in the same way that it happened for M1s.
And
So then maybe
Casey put a comment in the chat, and I'll just say that's another piece of the conversation that can't be forgotten, is while you're creating these new entities and you're combining entities, a place like where we live, I have no walk-in center, no ATU, no CSU, no BHCC. We have jail and ER, and many of your rural communities face that. So if we're going to put these,
I'm thinking the same thing, Michelle. It's a difficult conversation on the urban side, but then the applicability on a rural side is just even greater, right? Because we're trying to create entities like this, and the more complexities and pieces, it makes it so much more difficult for new entities to spring up.
Yeah. So I think even if this ends up with a resolution and we say, okay, we all feel really good about where this lands. They don't have to go to jail. They don't have to go to an ER. Here's what we've created. The next conversation immediately needs to be, okay, for communities that don't have these facilities, what do we do to make sure that these folks still have something besides a jail and an ER? And that's, to me, an enormous undertaking financially, because you've got to find something somewhere, something to do. Otherwise, you're back to your original two options and not much progress gets made except for your inner cities with all the resources. Like we said, we're not going to accomplish this today.
Well, this whole idea of intoxication management, I mean, it's
Yep.
almost like we need intoxication management facilities.
Yeah. Yeah, you just need like a sobering center.
Right.
And just to add, I have been to 15 states in the last year and a half, and we are one of the few that have two systems for handling two different types of individuals, an EC and an M1. Most states, their involuntary holds include unable to manage self due to intoxication, and those folks all end up on a hold in the ED where they're then screened. So we are kind of an anomaly in the fact that we have two of these paths to go down. Many states do not.
So that I'm really curious about that, and maybe you and I can have dinner or something.
Yes.
So like just in general, I mean, I spoke earlier, like, is this like combining them even a goal we want to have? I mean, in those states, the majority, it sounds like, where they're combined, do you feel like though, like, is it better? Is that okay?
Because again, I think that, again, such a long conversation. We should have dinner. You do end up, like, I will tell you that I know crisis clinicians that their heart and soul is in sitting with that suicidal person, navigating that psychosis that law enforcement doesn't know how to navigate. However, they want to quit their job when they are now told they need to go sit and talk with an intoxicated person who's not even going to remember the conversation tomorrow. There are passions that people have in this field. You've got your peers and your recovery folks that are so passionate about helping people get from the world of deep stronghold addiction to sobriety and recovery. But even though we want to say we can't talk about these things in isolation anymore, you do have to take a step back and realize there are people with passions that want to serve specific populations. That's the way of our treatment providers, our clinicians and staff have certain passions they love to do. And so, your hands are tied when you show up and the person blows a 3.6 with the police officer. You know very well they're not going to remember this conversation tomorrow. I've got to get them somewhere to sober up. One of the hospitals I work in just finished a hospital ER order set to be able to hold someone who was intoxicated without an M1 and without an EC, just so they could sober up to get to that crisis evaluation point, because there is no third option in the world. It's either you can put them on an EC and hold them and then get them to a detox, or you can put them on an M1, but if they're intoxicated, they really shouldn't be on an M1. This huge conversation of months culminated into an order set for the ED to feel comfortable, so physicians felt like they could keep people safe. But in states where this, like I was in one state, they don't even, when I said gravely disabled, they looked at me like I had four heads. They don't even use that word. They use this really long sentence of people who are incapable of taking care of their personal needs. And that lumps in substance use and homelessness. So you open the door to a million things.
Does that open the door like to physical health problems?
Yeah.
Like someone who's delirious or someone who has dementia? I mean,
Yeah.
that's a mess.
Yeah. Oh, it is really a mess. It is really a mess. And again, the crisis continuum across the country is exploding. Mobile crisis teams are popping up everywhere. Co-response teams are popping up everywhere. And they're the ones that actually have all the data because by and large, before this, it was law enforcement. Law enforcement was the one called to all these calls. So now you're throwing mental health to these calls and they're going, oh my God, wait a minute. And so your mobile crisis teams have a lot of firsthand knowledge of what they're seeing. And it's not cut and dry to say, okay, navigate it like this, good to go, you're blessed, go do your job. It is very, very gray. It is not always black and white.
So let's put a hold on this conversation and kind of figure out what's going to happen with this ASAM 4 changes. And maybe we'll pick this up again in a year and see how things are, maybe more than a year, because it's not going to be implemented until July 1st of 26. So let's give it.
Did you add that, Jessica, to the minutes?
I
That
will.
This combined EC process, we really want to take a pause on this and watch what happens as these facilities start to morph and what they find, and then come back to this, like you said, a year or more down the road.
Yeah, absolutely. I just want to be mindful of time. We've got about 6 minutes left. Anything else on this list that we want to maybe dig into further next time? A lot of it we've talked about, like training on pickup orders. We kind of have that on hold as well. It sounds like there's some court things. Sorry, go ahead, Tom.
Just wanted to say really quickly, I think that part of how these things wound up on the list was Ryan Templeton having engaged with a lot of these really powerful concept conversations, created this list to get input about whether BHA should do, and then internally what we refer to as concept papers. So when we challenge ourselves as an organization, every State Department does this, to ask its internal staff members to put forth ideas about what should change statutorily. So that's part of why we wanted to engage with this group, to know whether we should do a concept paper and then perhaps change statute. So it's a multi-year process, to Jessica's point, whether we should put forth statutory changes. Now, to do that typically takes a huge State Department lift, sometimes across different state departments to do that. So that's what would be necessary here. In addition to what Jessica talked about in terms of timelines, I would also add anything that costs any money is off the table for this year. We have no idea what next year looks like. So these big concepts, even if we all agree are something that we should take on, all is going to be in the lens of what this year does to us and then subsequent fallout for those kinds of things in subsequent years. I think we're going to be reeling probably for all the reasons we discussed earlier. Samantha, I see you shaking your head.
Maybe we could add to next meeting that we go through this and we prioritize and say, this is off the table. Let's just put this at the very, and maybe we literally take this list and reorganize it to, this one's actually feasible because as we created that subcommittee for writing the report to the BHA, we're going to have to dive into what is possible and what our recommendations are. And so maybe we spend a good 20 minutes next time, 30 minutes going through each one of these and saying, like that ECIC or ECM1 combining, that just drops right to the bottom of the list. We're not even going to talk about it. We're going to monitor ASAM changes. What about this? Yep. This is going to drop to the bottom. It's not within our control. This has a fiscal note. It drops to the bottom. And maybe we can just put at the top things that are achievable so that when we write that report to the BHA, we have something to focus.
I like that idea a lot.
Jessica, I know you were trying to wrap us up.
We've got just a couple minutes. Did anybody have any big 2765 questions? I don't think we have any that have been submitted to the questionnaire or public comments. we do have the next meeting is April 25th. There's a question mark on here around like, do we want it to be hybrid, semi-in-person? Given that we only have 3 minutes left, I say we move towards virtual and have that conversation in April for May.
For May, yeah, agree.
Okay. Are we giving 2 minutes back? Did we wrap it up quickly?
So that me just chatting that there's no money ever is not the last thing that is said here.
Are you sure?
I'm finding as like someone in a position to be thinking about like how to develop programs at an agency in the context of no money. Like when we are developing programs and there is money, as we have been able to do for the past few years, lots of times we're like moving too fast and don't have time for those concepts to be really rationally developed and then like put the right dollar amount on them. And so I'm trying to think about the next few years when I know we will not have money to do anything as years that I actually want to put energy into developing ideas that might cost money so that in a magic future where the financial situation in the state changes, like those ideas are developed and ready to have that like budget lens put on them, because we can't just say, oh, suddenly there's money, but we haven't talked about the things that cost money because there hasn't been any money. Does that make sense? Like now is the perfect time to think long term about things that will cost money and then talk short term about the things we can achieve within current budgets. And I think that gives me a little bit of hope in thinking about things.
And so maybe we'll block off like maybe 45 minutes instead of just 20 or 30 to kind of go through that list and figure out like, maybe let's put them into a timeline, right? Like, because we know we don't have budget for a couple of years, like what can we be working on? What are our really big projects over the next 2 years? So that when we hopefully get monies, I'm going to say 2 years.
Yeah, instead of just saying, well, let's not worry about that. We can't do it anyway. Like, let's start talking about it because it's big.
Well, if I
Knowing it
could just
won't
put a
be.
plug too as we walk out the door, I have never in my life realized how important it is to not just pay attention to a presidential election, but to really get to know the people who are running your state and your representatives that are putting forth bills, because I am appalled sometimes at what gets put forth and what people do and don't know. And that's where a state budget gets mismanaged and money gets lost and budgets get upside down. I am really pushing for people to really get to know the people that are representing their area and our best interests for our clientele at the state level. It's so much more than just the federal government decisions. It is our local and state government that get us into these places of no money. And now we have to kind of handle certain things. So it's such a big picture, but there's my plug. I just sat with a representative who had 2 bills on the table. One contradicted the other. And when I said, do you realize this contradiction? They looked right at me and said, no. So
deep cleansing breath.
It's important to pay attention to our state. Yeah. There's my plug.
I am speaking from a state perspective. We would have no money in the state right now, regardless of what's going on the federal level.
Oh, 100%.
Yeah.
So. That's what I mean. That's what I mean. All right, y'all, we're past our time. In lieu of Jen being here, I will say we are formally adjourned. Jessica, thank you for deciphering our minutes and putting them into our meeting and putting them into minutes, and we will see you all in April. Don't forget, if you are here as a public member, there is on the website for the state for the next meeting, a place where you can submit questions so that we can put them in here and have time allocated to discuss them. So if something's really important to you from today, go in there, stick it in there, and it comes up on our agenda to make sure we talk about. Have a lovely weekend, everyone.